Hi, everybody.
Hi.
This is the three wise techs this time around. We have Dianna Monno giving the first presentation, we have Jaffer Ahmed giving the second presentation, and we have Chief Scott Costoli giving the third. All of the talks are wonderful. I've actually gotten to see a couple of them, and we had a really interesting talk over Snapchat actually about strokes and everything else, which is kind of how this all came about. So, without further ado, come right on up.
Hi, I'm Dianna. I'm a nurse at LIJ in New Hyde Park, and I work on a telemetry unit, and we specialize in stroke. So most patients that have strokes, well actually all patients that have strokes come to my unit, we put them on cardiac monitors and all that fun stuff. So I figured I'd teach you guys about the NIH stroke scale that we do in the hospital, as opposed to what we do in the field. We use the face, arms, speech, time thing. So if you get a call and they're like, oh, patient has a suspected stroke, you're going to go and you're going to see if they have any drift in their arms, if they have any facial droop, if they're slurring while they're trying to speak. And usually you'll check their pupils to see if they're equal and reactive. But other than that, that's pretty much as far as you go in the ambulance. In the hospital, we do something a little different. So the NIH stroke scale is a tool used by healthcare providers in a hospital setting to accurately quantify the severity of impairment caused by a stroke, both ischemic and hemorrhagic. And we know the difference between ischemic and hemorrhagic strokes, correct? Ischemic is a blockage caused by either cholesterol, blood clot, etc. And hemorrhagic is a bleed. The stroke scale goes from, it ranks 0 to 42 in points. And I think there's like 16 levels, 12 to 16, like different categories that we go through. 0 is no stroke symptoms, all the way up to 42, which is severe. I was reading that if you have to have under, like, I think 16 to show any improvement, otherwise if you're past that, the likelihood of death, like, skyrockets. So the initial assessment is what you're really looking at to see if it's above or below that number. And usually we'll redo that assessment. You'll do it on admission to the hospital. They usually call it code stroke. They'll do it on admission to the hospital. Then they'll do it every hour or so, depending on how bad it is. They'll send them to the ICU if they give them TPA. And then they do that every hour. Otherwise, they come to my floor, and we'll usually do it every 4 hours. We'll do not the full stroke assessment. We'll do the full 16-point stroke assessment every shift, so every 12 hours. And then we do a neurogeneral, which is half of it, or a little less than half of it, which just shows arm drift, facial droop, alertness, and if we see anything different, we'll send them for an extra CT, we'll call the provider, etc., to see if the stroke's either evolving. Let's see. Oh, I was right. A baseline score of greater than 16 indicates a strong probability of patient death. A baseline score of less than 6 indicates a strong probability of a good recovery. And I usually see patients come in with a 6 or less, and they go back to a 0 very quickly. First, we're just going to check their level of consciousness. Most of the time, you look at them. If they're alert, then they score a 0. Not alert, but you have to like rub their chest or something. They'll wake up and you give them a 1. If you have to like literally sternal rub these people, then they're a 2. And if you can't get anything, then they're a 3. And usually in the computer, it's just like clickies, and it like calculates the number for you at the bottom. Then you'll ask the patient, can you tell me the month? And a lot of the times, like, they can't because they're just so confused. You'll be like, what month is it? And they're like, oh, it's January. And then you ask them how old they are. And if they can't tell you how old they are, then they score according to this. So if they answer both questions correctly, it's a 0. 1 wrong, and then 2. This one is commands. So if a patient has a severe stroke, they can't follow any commands. So you'll ask them to make a fist. And if they attempt to make a fist and they like are too weak to do it, it still counts. But you can see if they're actually trying. So you ask them to make a fist, and you ask them to close and open their eyes. Let's see. Oh, and I didn't mention before this. We always check pupils. So that's something that we do before that. We check and see if they're equal and reactive. And that's another thing that goes in according to this. So we're checking for gaze palsy here. So you'll ask them to follow your finger. And if their eyes deviate to one side, then you have to score them as higher, because that means that it's causing like a hemispheric reaction. So you're looking for that. But most of the time, I rarely see that. Like, the stroke has to be super severe for that to happen. I don't think I've ever seen it in the hospital setting. And then you're checking for vision loss. So what you usually do for the patient is you'll hold up, like, you'll have them cover one eye, and you'll hold up, like, how many fingers am I holding up? How many fingers am I holding up? But most of my patients are, like, confused because they're old. So what I do is, and what they tell you to kind of do is, you just come at them from the side. So look at me. I'll just go like this, and you'll see them, like, blink or something, because you'll be like, how many fingers am I holding up? And they'll just stare at you. And I'm like, okay. So the professionals tell you to just, like, jab at their eye with your hand. And if you see them squint, then that counts as no vision loss. I know, it sounds crazy, but that's just what we do in the hospital. We're looking for facial palsy. So you ask them to smile. If you see that it's symmetrical, then it's a 0. If you see that the nasolabial fold is flat, then you're going to mark them as a 1. And so on and so forth. And sometimes the patients can't even move at all, so it's 3, complete facial palsy. This is a big one. It's the drift. And this is what you see outside of the hospital as well when you ask them to hold up their arms, but there's like this whole classification for it. So, no drift, you have to ask them to hold up their arms for 10 seconds. No drift. If they glide towards the bed, that's drift. If the arm hits the bed, it's like, going over this with my preceptor was like the most ridiculous thing. So if the arm hits the bed but they're able to lift their arm up, then that's a 2. If their arm is on the bed and they can move their fingers, that's no effort. If there's nothing, then it's no movement. So usually when we do handoff with another nurse, like I'll go in there and be like, all right, can you tell me if it's a 2 or a 3? And they're like, I don't know. So we go in there together and make sure that we're both seeing the same thing because it gets very like misconstrued. Next. We do it with and then the legs, we do both. So the leg, it's only 5 seconds up, and it's the same concept. Drift, no effort, no movement. Ataxia. This one's good. So this is the finger to nose test. I'm using you as my patient. So touch your finger to your nose. Touch my finger. It's okay. Finger to nose. Finger to nose. Touch my finger. Very good. I'll do that with both arms. If they can't do that, that's considered ataxia. Same with your, okay. Take your heel, place it on your knee, and roll it right down your ankle. Beautiful. And then you do it with the other side. And if a patient can't do that, you slow them appropriately. And usually, these patients have a lot of difficulty walking if they have ataxia because they can't really control any movement of their limbs. Sensory loss. So what they show you in like the training videos is like using a pinprick. We don't have pins. I'm not going to poke a patient with pins. So usually what I'll do is like I'll just pinch their arms and I'll be like, does this feel more than the other on one side? And they'll say yes or no. And usually like if it's a right-sided stroke, they'll feel less on the left and da-da-da-da-da. So I'll pinch here and here, which feels more? And they'll say yes or no. And same with the legs. So we're testing to see if they're having any loss of fluency of speech. So patients who have strokes usually can't put words together, and it's actually pretty interesting when a patient can't do it because they'll just like talk in circles and nothing makes sense. So this is called aphasia. So what we'll do to test for aphasia, next slide, is I'll show them these pictures and I'll say, what do you see here? What is this? And some patients can't find the word to say chair. I personally don't like these pictures because like it's not, like, can you guys tell me what this is? Yeah, but some patients are like, oh, it's a swing or whatever, and you just give it to them. Like, what's this? Yeah, they're like little people because like sometimes they. But I give it to them because like it's confusing. And here, sometimes you ask the patient, what's going on in this photograph? They'll stare at it for minutes and not be able to explain to you what's happening. And we're looking for them to say, oh, there's a boy standing on a stool trying to get cookies out of the cookie jar. The mom is washing dishes and the water's coming out of the sink. But when you have a stroke, you can't verbalize that sometimes. So, all right, next. And then speech. So we're testing for slurring. So I'll have the patient read these things. They'll say, you know how, down to earth. Mama, tip-top, 50-50. And if I notice that they're slurring, I'll score them appropriately. I had a patient the other day who knew how to read before the stroke, and he was spelling these things. He's like, M-A, M-A, and he was like 50-something? And I was like, no, say this, T-I-P, T-O-P. I was like, no. But he improved later on, so. And this one, you're touching a patient on alternating sides and asking them to identify which side's being touched, left, right, or both. So it's kind of like you're trying to see if they can spatially recognize things. Usually you score them on like what the rest of the test was, according to this. But I've never, it's like, and most of the time they score between like a 0 and a 1. Do you guys have any questions?
The ataxia one, that's like a proprioception testing?
Yeah.
Okay. Yeah. That's what I was trying to figure out, because the reason why we had like the whole talk on Snapchat was because I had a patient that had failure of proprioception, and as they were trying to like wave goodbye, as we were like arming the patient, she like hit herself in the face, and I was like, wait a second, that's not normal.
Yeah.
It's like there's a lot more criteria than just like the simple stuff that you're seeing in the back of the ambulance. The FAST thing is not comprehensive. It's actually designed mostly for, we actually want to like actually make sure that the strokes that we do capture are the strokes that we can actually treat, whereas the full stroke scale that they use inside the hospital is more likely to capture everything.
And you can actually kind of see where the stroke is according to the test and how they score. And I mean, like, you end up seeing it on the rapid CT scan that they do, but it shows, like, the extent of the damage that the stroke is doing to the body. So, yeah. Yes?
What's TPA?
TPA?
TPA, yeah.
So, it's an anticoagulant. So, or a clot buster. So, if you, within 4 hours of onset of symptoms, if you get to the hospital and they do a CT and see that it's like an ischemic stroke, they'll give you TPA to try and bust it. And so they'll send you to the ICU for neuro checks every hour because it can cause bleeds, like major bleeds. Yeah. So they monitor you for, I believe, 12 to 24 hours after that in the ICU, and then they usually send them to my floor if they're stable. But TPA is like very effective in like busting these clots, so it's good. Yeah. What else?
And like, so would you recommend doing, like, if you're like in the field, would you do the full test like in the field or not?
No, you just get them in the hospital because you want them to get TPA.
Yeah.
And I've actually heard recently of people giving TPA in the field, which I'm like,
yeah, there's a couple of agencies that do that, but that's like a pilot program.
Yeah, I'm like, ah.
So it happened once in New York, and the guy died, and it will probably never happen again. Because he was given my medics. There are places, Texas is one of them, that has a stroke ambulance. It's run by a doctor, and he does a CAT scan in the back of the ambulance, and he can then decide to do TPA in the field.
That's different.
Yeah, yeah, a bunch of medics doing it in New York.
Well,
the guy died.
Presby has the stroke ambulance.
Yeah.
Oh no, I had a patient who had TPA, and they sent her to my floor, and she died.
Yeah.
They didn't want to do any interventions. Like,
medicine is a practice. We're practicing. We're practicing on you.
I do want to comment on that last slide.
Yeah, can you help me? Because I'm always just like, and I just look and see if they like respond to other things.
The extension of the one-sidedness. I had a patient when I was on rotations in the VA hospital, and he had what was called left-sided neglect, and he just completely disregarded anything that was on his left side.
Yes.
So he'd be sitting down eating breakfast, eating his cereal, and we'd be talking how he loves his cereal. And then we take the cereal bowl that was in front of him and we move it to his left side, and we'd say, "Oh, how's your cereal?" And he would say, "I didn't have any cereal today." He completely forgot it. You would be talking to him, and if you just moved to his left, you were gone. You never existed. It was really cool, a little weird, very, very cool to see.
All right. Thank you.